All right, so we are recording. We are going to have a number of people chatting with you today about what goes on at our center. And these are some of the folks. These are the primary folks that are involved with our pilot grants program. Of course, we have Kate, our director, who we are getting on a link to the meeting. And we have Molly, who you'll hear from about methodology and our methods core. I will be talking to you about our team science core and the pilot grants program. And Julianne is our center manager. And people that may not be here today, but you would become familiar with through our program, John Fortney and Keeney Law.
Hello, hello.
And Tess, oh, John's here. Hi, John. Great to see you. And Tess is our coordinator. Next slide. By the end of the session, we hope you will be able to simply describe the SCRC pilot grants program for 2025 and have a good understanding of our RFA process and timeline. And as Tess said, when we were getting going, we're recording the meeting. So this will be available to people on our website, through the Department of Psychiatry, and then we'll put a link to it in the RFA itself and the landing page for the RFA. And you can pass it on to folks who were able to make it. And we'll post alongside with a copy of the slides. All right, next slide. This is where I want to turn it over to Kate. Kate, welcome. Sorry for the hiccups with our link.
Yes.
Please tell us about SCRC.
Hi. So yes, I'm Kate Comtois. I'm the director of the Suicide Care Research Center, which is a multidisciplinary center funded by NIMH. This is a photo from our kickoff a couple of years ago. So there's a large group of us. We have come together to improve suicide care for adolescents and young adult patients. And in this case, we're talking about 13 to 30 years old, their families and their clinicians in outpatient medical settings. So that includes primary care, neurology, adolescent medicine, etc. Our vision is that we want to build a better model of care as patients move through their outpatient medical setting that can be easily used, just parts of it or the whole thing, by diverse programs and other outpatient medical settings. Next slide, please. Thank you. So we all know that most mental health care is actually provided in outpatient medical settings, such as primary care. Or if we don't know that, it's an important thing to know about how our mental health ends up working in the American system. The outpatient medical settings often rely on the emergency department when faced with a suicidal patient. But we know that this is often unnecessary. It's overwhelming to the emergency room, especially we're seeing young people. I know our Seattle Children's ER has got quite a lot of suicidal patients coming in right now. The emergency room can be overwhelming to suicidal patients and their families. And if what happens is they get a safety plan and referral back to primary care, there may not have been a whole lot of point to the whole thing. And we know that there is a collaborative care and other integrated behavioral health models spreading out through the primary care and other medical settings. But what we're seeing is the suicide care part of it is really lagging behind. Next slide. So what we have done is come together as a transdisciplinary research team. So this includes clinical and health services researchers, suicide researchers, biomedical informaticists, other disciplines, including geography and epidemiology. And our goal is to kind of come together and by sharing all of our perspectives, develop new frameworks, concepts, and methodologies that will improve the care that adolescent and young adult patients experience in their medical setting, as well as the experience of their families and the clinicians who work with them. Next slide, please. So this is the organization of our center. At the center of our center is our coordinating core. So that's led by myself and Julian Salisbury, who is a social worker and our center manager. And we coordinate all of the different elements of the center. The research projects is over here on the left. So we have our signature and exploratory projects that were planned when the center was proposed, and then our pilot grants that are currently in progress or funded. Our second round has been slowed down by our 6-month delay in funding from NIMH this year. We have our methods core led by Molly Adrian, co-directed by Andrea Hartzler, Trevor Cohen, and Kevin Hallgren. And they have done an amazing job of putting together our theoretical model and that or conceptual model that we developed for the proposal, and really infusing it throughout the center. So we have a whole set of resources, training resources, and intake and other processes that keep all of the studies in the center kind of in the model and provide them the assistance they need to do something innovative, since our model is new for most people. Our team science core, represented by Dorian Darnell, who's leaving and taking over as Keeney Law, and John Fortney has been with us. This is where we coordinate our collaborating scholars and our pilot grants program, and provide center-wide training and mentoring for the folks who come through as multiple PIs on our pilot grants, as well as our emerging collaborating scholars and our advanced scholars. Can we do another slide without losing this page? Yes, great. The policy core is kind of innovative. Most centers don't include this, but we really, right from the start, wanted to be sure that the products of our center make sense in the larger world of suicide prevention, things that are being funded, things that are being implemented. There's no point in us developing things that really have no legs to go anywhere else. So this policy core is directed by Julie Goldstein Grummett, who's with the Zero Suicide Institute, and is co-directed by Colleen Carr from the Action Alliance for Suicide Prevention, 2 national leaders in suicide prevention. And we coordinate non-academic mentorship of our studies, so that right from the start and all the way through, the studies are staying in touch with what's actually happening on the national scene of suicide prevention. Next slide. So do you want me to give this to you now, Joanne?
Yep, that'd be great. Thank you. I'm going to tell you now about our pilot grants program, and our team science core, like Kate said, leads that effort. But we are all integrated in this center. We're all working together, and everything affects and supports each other. And like Kate said, I am leaving the center, sort of leaving my position at large at UW. So I'm here today. I'm through October, but after that, you'll be working with John Fortney and Keeney Law and Tess Grover. All right, we fund developmental and pilot research that we hope will lead to future grants. This is really important part of our aims of enhancing the pipeline of transdisciplinary research. And our projects need to be aligned with the center's aims, obviously need to be about adolescents and young adults in outpatient medical centers, and need to align with our methodology. So Molly's going to go into a deep dive about the methodology for you after I share about the program. We also just want to point out that, there have been a lot of federal policy changes in the past year. And there's a lot that we're learning and a lot that people are still kind of confused about, but NIH did post some strategic priorities for research. So we really encourage you to review those, because projects will need to align with NIH funding priorities as well. And then I'm going to tell you about all kinds of wonderful resources we provide to our grants that have to do with not just supporting the dissemination of the findings, but many other things to help you with implementing the grant. Next slide. We are awarding 2 pilot grants this year with a start date in March of 2026. Grantees receive $100,000 over a 2-year period. Projects must be aligned, like we said, with the suicide care pathway and center methodology. And they also must promote transdisciplinary research. So transdisciplinary research, like Kate was saying, has to do with bringing in multiple disciplines. We need our projects to have multiple principal investigators from different disciplines. And the other thing that these projects need to have is clinical partnership. That also makes the science transdisciplinary when we are partnering with clinical and community partners. You might be wondering, well, what makes something a different discipline? We really want to see people who are coming from different arenas that can bring things together synergistically. But we sort of define discipline as if you're coming from different academic departments, if you're coming from different training backgrounds. For instance, if you have someone in pediatrics partnering up with someone in informatics or someone in design. Other common disciplines we see is nursing, psychology, psychiatry, engineering, social work, but you can get creative with that. We do ask that one investigator have previous suicide research experience as evidenced by publications, grants, or theses or dissertation. And we welcome investigators across all career levels and investigators outside of the UW, but we cannot award to international investigators at this time. Next slide. We really want our projects to succeed. We are really excited about our investigators, so we offer a lot of support. And in addition to funds for disseminating findings, like I had said earlier, we also offer a monthly seminar where you would meet with John Fortney and Keeney Law and some other folks from the UW Alacrity Center who are doing similar research. Attend a monthly seminar to help with project implementation. We offer a host of wonderful didactics, some of which we're definitely going to encourage you to watch before you write your grant or write your letter of intent. So we offer a lot of didactics, center meetings. Our projects can present their work and get feedback at center meetings from a bunch of experts in the area, interdisciplinary experts. You can get methods consultation for your project. You can get feedback and support highly tailored to your future grant that you would write from a grant writers workshop we do partnered with the Alacrity Center at the University of Washington. And then Kate, I think, may share a little bit more later about our non-academic mentorship that we provide 3 times a year, 90-minute workshops. Then you can get talk with people with lived experience, policymakers, and outpatient medical providers, and give feedback on your project. Next slide. We also invite all of our pilot grantees to join our Emerging Scholars or Advanced Collaborating Scholars programs. And what we do here right now primarily is offer additional mentorship to early career scholars to advance their work in suicide care research, as well as funding for training or education in areas that would help advance the scholar's suicide care research trajectory. So it's really about career development and keeping folks in our pipeline of being investigators in this area. We do open the program to non-grantee investigators who are just interested in working with the center and learning from the center. We have an application process for that for our Emerging Scholars program. And you basically get access to very similar things that our grantees get access to, and you get the mentoring as well. We try to connect people with mentors. We are not reviewing applications until early next year for that program, but we do have some folks already who are scholars with us, both grantees and not grantees. And we have an advanced scholars program that we're in development with. So there's not an application for that. But if people are interested in collaborating with the center who are already advanced, experienced in their career and research area, but are new to suicide care or want to bring their experience in their unique discipline to that work, please contact us. And you can get in touch with us at our UW SCRC email. Next slide. We think it's fun and helpful for you to hear from some of our grantees themselves about what it's like to work with us. So we've asked for some feedback, and I'm just going to share with you some of the things they've said. Being able to have access to experts in the different methods and analyses we're using is so helpful. Ongoing guidance and feedback that has been helpful in hiring a research assistant, identifying weaknesses in our initial research plan, and how to address them, as well has helped us plan for navigating challenging recruitment areas. I have particularly enjoyed having a chance to network with others in the field and learn from each other. It is not only inspiring and motivating, but very practical in that we share lessons learned and new ideas. Monthly check-ins help keep us accountable and on track. Hearing about other projects and things folks are working on has helped us gain insight into existing and ongoing work that can inform our projects as well. Next slide. Since we're a few years into our center, we have been able to establish even more resources for our grantees and collaborators, and I'm going to turn it over to Kate for this slide to share more about that with you.
Yeah, so one of the things that MethodScore has done is to build a REDCap survey system that has both the developmental discover, design, build phase, as well as our larger randomized controlled trial phase, so that we have projects that are already built out with our measures, and lots of the complicated sort of details of how do you send and receive communications to folks. For instance, we have the follow-ups all pre-programmed so that things can come out to our participants by text or by email. They usually prefer text, so that they can complete them quickly. And we're seeing very high follow-up rates, over 80%, sometimes over 90% with using this system. So we really encourage that. Next. We have developed a lot of documentation for how to put things into EPIC, which is the electronic health record used by UW Medicine and Seattle Children's. So you can integrate, if your interest is using EPIC as a vehicle for your interventions that you're developing, which we would highly encourage. We have already infrastructure that you can hang that onto, as well as contracts with programmers at EPIC that we can also lean into in terms of giving you assistance in being able to do this. Next. We also are harmonizing all the data that comes out of the REDCap data system with that's collected from the participants with the EHR data from the UW Medicine and Seattle Children's, so that they can be harmonized for data analysis. This meets our MethodScore aims, but is also something that might be of interest for an RO3, for instance, to look and understand more about the population of patients who have come to our center. And we can also assist with data projects that involve extracting data from the health record system. Next. We have developed a lot of risk management infrastructure. Sometimes people from other fields have justifiable anxiety about working with mildly or even highly suicidal participants. And so we've really got a lot of suicide expertise in this center, so we've developed measures. We have IRB protocol language, risk assessment strategies, training in all of these so that you can build a proposal that will kind of give you the infrastructure you need to manage risk if you're working with suicidal adolescents or young adults. Next. We have existing relationships with clinics, both within UW Medicine and Seattle Children's, and with primary care networks like the WPRN to assist the MPIs in finding real world clinical partners. So we really are looking for work that exists in clinics in the real world as much as possible, or settings where they're comparable enough that any intervention developed would work or have potential to work in a clinical setting. So please let Molly and I know if this is of interest for you, that maybe you have an idea, but you don't have a clinic, and we'll help to do a little matchmaking there. Next. We have very robust staff support, and we have folks here who know all of the procedures of everything that we do and can help train your staff. And if you end up needing just a small amount of FTE and doesn't make sense for you to hire somebody, you can work with our center manager to see who among our existing staff would have available time. We have also advisory boards and panels that provide ongoing feedback. As I said earlier, we have folks at the policy, advocacy, and funding level at the national level. We also have boards and panels of people with lived experience of suicidality and other opportunities to gather this feedback that's outside the academic sphere.
Great, thank you. Hopefully we've piqued your interest quite a bit in our grant, in our RFA, and now I'll tell you about how do I even apply for this. We use a two-step application process to support our applicants in developing competitive applications. And we have all the instructions and materials you need in a pretty well-detailed RFA that is available at this REDCap survey link. So if you take that link, it will drop you on a landing page in a REDCap survey. You'll have access in an attachment to the request for applications, and then you will use that landing page survey to go through our step-by-step process here of how to apply. You will need to submit a detailed letter of intent if you would like to apply by November 16th, 2025. So that is a midnight, essentially, due date through Sunday there. So we get to see how many letters of intent we have by Monday morning. You can also receive optional consultation from Kate or Molly on the development of your letter of intent. So by November 16th, you could have had input from Kate or Molly on how to put your best foot forward, best align with the center on your letter of intent. And I just really, really highly recommend this. It's optional, but highly recommend. The RFA has instructions for how you can request this pre-LOI consult. It's going to include emailing our center and submitting some written materials to Kate or Molly prior to the consult. And like Kate was saying, if you need help finding an MPI or a clinical partner, this is a great time to do that with them. We ask that you review the methodology resources that are listed in the RFA. It'll include some webinars that have been recorded previously. They're fabulous. I can't recommend them more highly, but you want to view those prior to submitting your LOI, and definitely prior to the consult. It will really help you have those conversations. We will invite then a subset of applicants to submit a full application based on their letter of intent. And if you are invited to apply, you'll get written feedback on your letter of intent from center faculty, just to give you a little bit more support there on your application. And the next slide is going to go over the steps and timeline in a visual diagram. Next slide, please. All right. If we work backwards from the gold star, we will let applicants know about whether or not they are funded on February 20th of next year with a start date of March 2nd. Those invited to submit a full application will need to submit this by January 11th. Potential applicants who submitted a letter of intent will be notified whether or not they're invited by November 25th. The optional one-to-one consultation with Kate or Molly on letters of intent is available starting today and goes through the end of the month, October 31st. And we ask that you make your request for this meeting by October 24th. And now Molly will share with you about our center's suicide care pathway and methodology.
Great, thanks, Diane. All right, so applicants, you know about the center now, and you know about the process for evaluating pilot funding, and I'm going to walk through the frameworks that guide our scientific activities in the center to help ensure that the project that you're proposing aligns with the work that we do. So this slide highlights our research activities that are focused on the suicide care pathway. So you can see this top row outlines suicide prevention activities that could occur in the outpatient medical setting. So this ranges from risk detection to longer term follow-up. Our model also articulates that each the sort of theoretical mechanisms that are important for the center are the acceptability and usability of the intervention, as well as therapeutic alliance and self-efficacy processes between the outpatient providers and their patients. So our proposed model, these intervention components we want them to be as acceptable and usable as possible so they ultimately can reach patients and improve the therapeutic alliance and self-efficacy. So we have reach in our model, even though that's aspirational. It's sort of outside of the scope of the work that we're doing, but we think it's critically important to consider because without reach, people will not be receiving the interventions that we are developing. So we really want to increase the number of patients who receive effective interventions. And so we keep it in there to remind us of our ultimate goal. Next slide, please. So we are seeking to support projects that improve the suicide care pathway, and we have adopted 2 frameworks to promote this work. So the first overarching framework is the multi-phase optimization strategy, also called MOST. MOST is an engineering-inspired framework that intends to optimize and evaluate multi-component behavioral interventions that balance effectiveness with affordability, scalability, and efficiency. So the MOST framework is divided into 3 phases. The first phase is preparation, where we are really identifying candidate components. The second phase is optimization, where we evaluate each component separately, decide what is included and excluded in this optimized treatment package. And then the third phase is evaluation, which is determining if the fully optimized intervention works compared to some other intervention. So we've also expanded and articulated the preparation phase of MOST to integrate user-centered design methods and adopted the Discover, Design, Build, Test framework as the second framework guiding our work. Next slide, please. So as we're thinking about the components of interventions, these are really the building blocks and are defined by MOST as any part of the intervention that can be separated out for study. So these can be features of intervention content, like a screening measure or a safety plan or peer support. They can be features of delivery, so whether it's telehealth or in person, or the length of sessions or who delivers the component. Can also be a strategy to improve compliance, so like reminders or gamification. And it can be features to improve fidelity, so it's technical assistance or training. So the preparation activities that we think pilot grants will focus on are around identifying, refining, or piloting these candidate components for the next step of the model. Next slide, please. So as I mentioned, the DDBT framework is the user-centered design framework that we have decided to focus on in preparation phase activities. So this, all research projects in the center are asked to align with this process. So Discover is around identifying the needs and perspectives of the people who will be interacting with the intervention, and to understand the context of use in terms of the barriers, constraints, and facilitators that are faced in that unique setting that you're proposing. And if that Discover work has already been done, your research team has already done that, just articulate it in your proposal so we know exactly where you stand with regards to the evaluation of the intervention components you are proposing. The next phase is the design phase, where you're synthesizing the design requirements against the user needs and iterating a number of design concepts that could be good solutions. The build phase is where you are developing low fidelity prototypes and then refining them with a solution. So this design build is a iterative process that is meant to be interactive and flexible. And once you have settled on a refined solution, you're going to move on to the test phase, which is where you would pilot the high fidelity prototype that you have worked on in your design build phase. Next slide, please. So for this RFA, we're really interested in projects that focus on scalable intervention or service delivery strategies along the suicide care pathway. So these two areas are really required to be responsive to the RFA. Next slide, please. We thought it would be helpful to give you some ideas of activities that would be consistent with the requirements, and also show you some of the projects that have been funded in previous rounds. So some preparation activities that would be consistent would be conducting needs assessments for a novel intervention, operationalizing your optimization objective that would be completed in the next phase, the optimization phase of the MOST framework, conducting a usability evaluation of intervention components, or doing pilot testing for intervention components. Next slide, please. Okay, so let's see, I guess 2 cycles ago, we had 2 projects that we funded that were highly aligned with center goals. So I thought I would just give you a preview of some successful projects that have been supported by the center. So the first is the HOPES project. This project sought to understand the needs of adolescent and young adults and their caregivers with respect to caring contacts and remote suicide risk monitoring in primary care. So this team has developed a conceptual model. All projects will be asked to develop a conceptual model that highlights their intervention components, their mediators, their distal and ultimate outcomes. So you can see here that this team's conceptual model has the intervention components of caring contacts, of risk monitoring tools, and then educational content. And then they've identified target mediators of belonging, timely support, and self-efficacy, with distal outcomes of engagement and satisfaction, and an ultimate outcome of reducing suicide risk. So this project has focused on having the protocol for these components, and then presenting those protocols for co-design with their co-design partners to refine them. Next slide, please. A second project that was funded was called Wise Path, and this project aims to identify design requirements and prototype the components for an app that is seeking to support adolescents and young adults who are at risk for suicide. So their initial conceptual model highlights the intervention components to be presented in the app. So this included a crisis kit, goal setting, rewards and positive reinforcement, skills for youth and parents, and then shared stories in the resource library. And you can see those are each intervention component is connected with a target mechanism, and then their ultimate outcome was to decrease risk behaviors, increase functioning, and increase engagement with appropriate services. So these two, we hope that the two funded projects give you an idea about how we are supporting projects that identify components that are likely to be effective and adopted in the suicide care pathway, that they utilize DDBT methods to complete preparation phase activities, and they are likely to lead to future federally funded projects. So I'm going to highlight, now that you've got an idea of some of the projects and the methods that we use, some of our common data elements that we ask projects to use to make sure that we can integrate center findings and really make the center more than the sum of its parts. So when projects are using using our frameworks to look at acceptability, feasibility, and usability, we're asking them to use measures that are common across the center. So we've highlighted these measures here. We are to be consistent with the center. We want everyone to be using the same measures. So if you are measuring that construct, please, please, please use the measure that we have adopted center-wide. Next slide, please. We also have, this is less relevant for pilot awards, but if you are collecting patient outcome data, we also have required and recommended measures for those constructs. So most of the pilot projects are in that preparation phase and will be focused on acceptability and usability. But if you are collecting patient outcome data, we would also like you to use the measures that we are using. So we've outlined those here for suicide outcomes, patient-reported moderators, and intervention mechanisms, as well as our implementation mechanisms we've already highlighted. If you have questions about the required measures, I'm happy to talk with anyone about those. They're also linked in the RFA, so you can have access to what we are requiring and recommending. Okay, next slide. So the methods core will help support projects across your application and study life cycle. So as Doyen had mentioned, Kate and I provide pre-award feedback on your LOI. And if we have questions from your LOI that we feel like our methods core need to weigh in on, we will ask for their expertise at that time. And our methods core faculty are also on the review committee, so we can ensure that we're evaluating your proposal with all of the expertise that we have at the center. We also provide consultation and mentorship. So if your project is awarded, you will do a methods core intake with us so we can make sure that your project is consistent with center activities, that we're aligned with data collection strategies, and answer any questions that you have in ways to have the highest impact research possible. We'll also meet with you during phase transitions. So if you move from discover to design build phase, we'll talk with you about your discover outcomes and ways to prepare for your design build phase. We have a seminar series that provides guidance on our frameworks and ways to approach the research questions that are most relevant to the center. As Doyen noted, these seminar series are viewable asynchronously and are linked in the application. So please watch the 3 that are highlighted because they will help you to ensure that we're speaking the same language and using the same methods in your application. And then Kate had already highlighted, we have a centralized REDCap data capture. We have technical assistance and support in a variety of ways that are real benefits of working in the center. Okay, so that rounds out my comments about our methods. We wanted to make sure that we had some time to answer your questions and get feedback and clarify anything that's unclear.
Thank you, Molly.
Yeah.
And people could just jump in, or you can put something in the chat.
Hi, oh, go ahead.
Oh no,
I'll go second.
If it was silent, I was gonna pop in with a frequently asked question, but I see people have warmed up and are ready.
Okay, I'll go. Hi, I'm Sean Mitchell. I'm an associate professor at Texas Tech University. This is a really exciting opportunity. Thank you for all the information. I'm thinking about a potential MPI on a project and was curious about your thoughts about too much overlap or too close. We may be too close in background. So I have my PhD in clinical psychology. I mostly focus on adult suicide risk and prevention. The MPI that I was considering is in my department. He's a clinical child psychologist with a background in pediatrics and health psychology. And so I thought that would be kind of a nice overlap. We've collaborated on things, some projects before. And so I was wondering if with that little bit of information, if you think that that's kind of too close to meet kind of the expectations of the MPI roles.
I have a feeling that our reviewers will find that to be too close. But
Okay.
what you might want to do, one option for that is if you guys make a great team, you might want to add a third MPI who does provide unique in a disciplinary perspective. So that said, I think the spirit of the award is if you can make the case that you're really coming from different disciplines that are bringing synergistic and novel information together, you can go ahead and work on making that case. I will say we tend to see psychologists the same, but I'll let other folks chime in from Kate, John, Molly. What are your thoughts?
I agree with your comments.
Thank you.
I have a question. Hi, I'm Miriam. Hi, Molly. I'm a acting assistant professor at UW and at Seattle Children's Hospital. And I was curious what phase of DDBT you're mainly looking for projects when folks apply for this grant.
They can be any preparation phase activity that you would like. So it just depends if there has been no discover work and you're jumping into design build, that wouldn't be reviewed well because you're missing a critical step of understanding the user needs in their context. So if you've already conducted the discover work and you can articulate what the needs are from the AYA's providers and AYA caregivers, then you have a compelling story to jump into design build. Does that make sense?
Yes. Thank you.
Yeah.
All right, we have a chat question. Hi, Julie. Thank you. Julie says, I'm a lived experience individual who has also started an international initiative called What I Would Have Missed. I'm currently working with my local Zero Suicide, local university student services, and others. I'm interested in pursuing a partnership and are sitting on a lived experience advisory board. Is that possible? Thank you for considering my question. Wonderful work, Julie. Fantastic. And how awesome to be wanting to get on an advisory board. It looks like Kate has responded. That is terrific. We would love to follow up with you so we can connect with you after the meeting.
Okay, thank you so much. I appreciate it.
Yeah, thank you. Molly, you said you have a frequently asked question on tap. What have you got?
I'm glad there was a question about the different disciplines because that is often asked. I was also asked, and I could not recall, if you are have some investigators at UW and some in another institution, do we have to cover the subaward indirects within the $100,000, or how does the budgeting aspects of that work? Or should we wait to instruct people at the next phase?
Yes, and we really are encouraging applications from outside of UW just as much as inside UW. And the subcontract can be a bit of an issue for folks because it will eat into your $100,000 budget to cover the indirect costs for your university.
So that's a number that's related to your university developing a subcontract with UW. There's no UW number that you'd be thinking about there.
Mhm. Other frequently asked questions from Kate, John, Molly that we remember getting?
Hi there. While you're thinking, could I possibly ask a question?
Yes,
All
thank you.
right. Thank you for the presentation. I'm affiliated with a large community-based organization and not-for-profit healthcare system, essentially. Well, part is not-for-profit, and we are not an academic institution. We have small pieces that may support specific academic research, but not to the framework that you've described. However, I do feel like our organization is set up to potentially implement some of the pathways and or further findings in a community-based setting, which I think is very meaningful in understanding how this research can be applied to different settings. So I was just curious, would I possibly be able to talk with anyone about a little bit more about us to see if we're appropriate for grant application, or is that a hard stop already just based on information I've shared?
Hey, what are your thoughts? I'm not thinking hard stop. I'm thinking, yes, great, please reach out to us and talk more. But Kate, what are your thoughts?
I think that's right. I mean, whether we, I think thinking about sort of this MPI format, a lot of what we're looking at is people's applying for the next grant, that this is really sort of preparation for the next academic grant that's going out. These days we're kind of shifting around as to where we would have said for sure an NIH grant. I'm not sure exactly how all this is going to play out over the next year or two. So I think it's worth a conversation as to whether you all have enough of that structure and intent to be applying for grants. We certainly have colleagues who do that at Kaiser or St. Luke's and other places. So we would definitely want to discuss it. If not, it might be it's a partnership with some of our academic folks to do something at your organization. So yeah, please be in touch with us. You can email us at the UW SCRC, and we'll also, noting your comment, we can loop back to you as well.
Any other questions? Oh, Craig Bryan, hi.
Hi, hello. Sorry, I logged on late. I just saw the message come through about 10 minutes ago. And so I see that it is being recorded. Will it be available for us to come and watch? Okay, thank you.
Definitely. Yes. Thank you. I think I would just put a plug in for that pre-LOI consult. It's extremely valuable. When I think sometimes people have wonderful ideas and wonderful projects, and we hope they get funded somewhere, but they just couldn't get funded by us because they are not quite aligned. And so I want to help people figure out what is it we're trying to do here at the center and see if they have a project that aligns with that. Yeah.
And just to clarify that that Molly and I, in having that consultation with you, we then recuse ourselves from the scientific review, so that so just clarifying that you're not talking to a reviewer of your project. We usually are in the matchmaking business around this project, and helping people find, also, if you don't have an MPI and you're looking for that, these are the kind of things to consult with us about. And so we kind of hang on to that role, and other members of the faculty will actually review your proposal.
Great point. All right, well, I see we're just about at time. Thank you everyone for coming. We are so excited to see what you all are bringing to us. Please pass around the link for the RFA as well, and the video. Bye.